So it is basically a congenital heart disease, which is rare, but it's also the most fatal congenital disease in general, not heart disease, but disease in general. And it is characterized by various degrees of hypoplasia of the left-sided structures of the heart. So this affects the mitral valve, it affects the aortic valve, it affects the aortic outflow tract, the arch, the descending aorta. It primarily also affects ultimately the left ventricle. And what I will very much focus on is the ventricle itself, rather than talk about any procedures or any related aspects to the valve disease underlying hypoplastic left, or HLHS, hypoplastic left heart syndrome. The reason being is, as you will see while I give this lecture, is that it's all interconnected. And we need to understand this as a combined disease that has multiple angles that we need to address with regard to treatment. So what is the current management in the majority of the cardiac centers around the world, which I call here should be the past. It's not necessarily the past, but hopefully at some point it will be the past, is the three-stage Norwood procedure. As you can see, I'm from Boston Children's Hospital, and that's why it's the three-stage Norwood procedure, because Bill Norwood, when he was a fellow under Lucas Daniela, at some point in the past, created this approach to rerouting the blood in order to make the baby and survive, not only survive, but also thrive. And now these children are adults, they are parents themselves. And so we've come very far with regards to this. However, what we're also faced is with the impact of this non-physiologic circulation. The alternative is heart transplantation. We all know that due to the scarcity of organs, this is not an option in general, and it also bears its risks with regards to the rejection of an organ and retransplantation. So our goal is to look at preserving the left ventricle. So basically managing these babies affected with hypoplastic left heart syndrome in order to maintain a viable left ventricle that might have the opportunity for growth as we manage this disease along the way. So we start off with thinking about what does it entail to pursue a biventricular repair. We start in utero. So for the now almost 25 years, we have been one of the leading centers for fetal intervention. And so the intervention by dilating the aortic valve has changed the trajectory of some of these patients. What we also do is to figure out associated malformations, associated pathologies that we might be able to address for now primarily surgically, but as I will introduce to you, also our thought of process is towards introducing adjunct therapies. And so the focus primarily of this presentation will be on this tissue that you can see here in yellow on these 3D reconstruction, which is basically covering the entire surface of the left ventricle. And basically in incorporating this entire left ventricular myocardial structure with this stiff tissue, which is called endocardial fibroelastosis. So what we have, by looking back at our own data, what we found is that despite successful dilation of the aortic valve in utero, these children are still restricted with regards to the growth of the left ventricle due to the degree of EFE. So EFE is short for endocardial fibrosis. So the more EFE there is in the ventricle, the less likely that this ventricle can adjust and be useful for biventricular circulation. So again, looked at our own data. We looked back in order to determine, so what happens to our patients when we resect this EFE? And we did this in a retrospective analysis. And we all understand retrospective analyses have their problems, have only provide us with some information, but at least it is good enough information in order to further explore the next steps or start discussing what kind of options we have in addition to what we already know. So we looked at our own patients, all the patients that underwent EFE resection in an 11-year time frame were retrospectively analyzed by looking at medical records, imaging data, CAT data, and the reports that the surgeons provided us with regards to EFE. So we identified 92 patients who fell under this perspective. And one of the first aspects was for us to just determine time to recurrence. So does EFE come back? Clinical observation indicates that it does, but we were not quite sure if this is true because just because somebody says so doesn't really mean that it's really happening. And in addition to that, what we were interested in to figure out whether or not we can define a predictive model in order to determine that what triggers EFE to come back. The reason for approaching EFE this way is because these data are available, and it is very difficult to start with in utero data in order to determine the development of EFE, but at least we can determine progression and recurrence of EFE postnatally. So this is why we started at this postnatal time point. So first of all, the good news. The good news was that when we looked at our data, out of these 92 patients, the majority actually saw, after resection, of the primary resection of this EFE tissue, saw growth of the ventricle. Growth is not meant in the sense of growth that we see in utero or so in the fetal environment, but growth in the sense of adaptation of the ventricle to improve its size adequately to the stage of age this patient is in. So when you look at this graph, where we looked at Z-scores and we looked at volume, we looked at left ventricular volume, we looked at left ventricular wall thickness, and we determined left ventricular mass to volume ratio. And as you can see, we start with a small ventricle with a Z-score of over 2 prior to any kind of intervention. But when we look at 1 year post-resection, and also, it's not resection alone. It's also associated with other reparative interventions to preserve the left ventricle. We see that the Z-scores goes down to 0. Basically, this is a normal-sized ventricle. So, in addition to that, what we can also say is that EFE resection does improve outcome because over 70%, so almost over 2/3, almost 3/4 of our patients are either already supported by biventricular circulation or are in the stage process of becoming biventricular circulation. So so normal, basically more or less normal hearts. So that's the good news. The other aspect that we looked at is, so what did we find, yet again, retrospectively, as risk factors for EFE recurrence? So what kind of hemodynamic situations elicit a recurrence of EFE. So what we found is disturbed inflow, so basically mitral valve, persisting mitral valve disease. What we also found is the diastolic compliance, so increased stiffness of the left ventricle as being at fault. And the third one is left ventricular outflow tract obstruction, but very focused on the aortic annulus rather than the aortic valve. So the aortic valve annulus, that if these children just undergo aortic valve dilation, is obviously not corrected. And yet again, looking at our retrospective data, focusing, I mean, we have to start somewhere on the aortic valve annulus. We looked at our patients in order to determine, and this is in collaboration because in order to pull off a retrospective analysis like that, you need the necessary patient numbers. So a big enough cohort in order to statistically analyze this data. And this is in collaboration with the center in Linz in Austria. And what we did here is to look at all of our patients and compare the ones that underwent permanent augmentation of the left ventricular outflow tract or the aortic annulus through surgical means. What I'm talking about is the Ross or Roscano operation. And in a multivariable competing risk model, by finding control patients that are matched in all aspects, except for the fact that they did not undergo Ross or Roscano procedure. What we found is that the risk of recurrence in patients that did not undergo permanent augmentation of the left ventricular outflow tract had a almost so a fourfold increased risk for EFE recurrence. So having said that, so this is kind of looking at our own data and kind of evaluating whether or not EFE really does play such a significant role in this disease process. So now let's talk about EFE in general. So what is EFE? So EFE is this is an echo of one of our patients. This is a hypoplastic ventricle on the left, and you see this. First of all, obviously it's not apex forming, so it's hypoplastic. So, and we see this whitish tissue here that is covering the entire surface of the left ventricle. So I have already conclusively shown to you by looking at our data that it restricts physiology. So it is a major determinant for diastolic dysfunction, and it also impairs growth. And if we resect it, we can correct both of this. So how do we correct it? By surgically removing. That's at this point the only way for a corrective intervention. And as you can see, now the echo whitish tissue is now here. The surgical direct view of the resection of this thick fibroelastic tissue. And then what happens? Well, the problem is the tissue comes back. That's the bad news. Despite all of our efforts, despite our good intentions, despite our good results, the tissue comes back, it grows back, and it grows back more viciously by infiltrating the underlying myocardium. In addition to that, this is another study from our institution. The outcome of with regards to a composite endpoint of death, transplant, a single ventricle palliation, or hemodynamic failure is all directly associated with EFE. So if no EFE is present, then only less than 10% of these patients suffer from any of these outcomes listed here. However, the rest is affected by this outcome. So now let's go back. What is EFE? So EFE presents, and you can see here, this is a pathological specimen where you can see this thick tissue that is covering the entire left ventricle. It is subendocardially. It is rich in collagen and elastin. It is cellular, so there's a lot of cells in there, but there are no vessels. So it's not necessarily the same kind of tissue that you would expect following a myocardial infarct. So it doesn't resemble directly scar tissue, but it's really this unique EFE this endocardial fibroelastic tissue. And what we have also found is that TGF-beta, which is a growth factor, it's a pro-fibrotic growth factor, plays a major role in this process. So having said that, we took advantage of this unique opportunity, and the tissue that is resected from the OR is now transferred back into the lab, and this is one of these pieces of tissues that the OR provided us with, and we can look at the tissue. We can do multiple things with this tissue. One of them is just to histologically look at it, and this is what it looks like. So this is a specific stain that stains collagen in blue, and this is the myocardium, the myocardial bundles. And as you can see here, so to my right here, this is the lumen of the ventricle. So you can see the here is the lumen, and so this should be a single layer of endothelial cells, which is the endocardium, with a little bit of scarce fibrotic tissue, the basal membrane, with a few neural cells, but that's about it. So it should be a very, very small subendocardial space until it continues on into the myocardium. So the pathological aspect of this is this thick layer of blue. This is collagen. And if I stained it for elastin, it would also appear these nicely organized elastin fibers. And what's also pathological is these protrusions into the underlying myocardium. So this is all pathological, and this is all the EFE tissue. So what do we know? So when we looked at all of these, we were also interested in determining, so why does this, what is it, what are these cellular origins, and how does it transform? And it transforms by endocardial cells or endocardial endothelial cells changing their phenotype. So they become a different cell. So from this single layer of endothelial cell, which is the endocardium that are representing, now you get these cells that become mesenchymal cells. Mesenchymal cells are, for example, fibroblasts are mesenchymal cells, fall in this group. And they are the ones who are now, first of all, capable of migrating. So that's why you see this migration in the underlying myocardium. And they also become producers of extracellular matrix, of collagen and elastin. So this process of NDMT, or endothelial mesenchymal transition, is a physiologic process, but only during early heart development. So all of our valves in the septa are produced through this process. There are certain specific, uniquely identified areas within the heart, within the, in our case, the left ventricle, but it's also true for the right ventricle, the left ventricle, where the valves, for example, the mitral valve develops from the endocardial cushions, and the septa develop. But it's also been identified in pathological processes like fibrosis. This is true for the heart. So fibrosis like in heart failure, fibrosis in organ rejection following heart transplant, but it's also true for other organs like any kind of muscular organ, for example. And so how can we show that? How can we determine that? Well, we can do this histologically. We can do it by just, first of all, staining uniquely with unique markers for endothelial or endocardial cells. And these are these markers. So these are in green. These are the cells that have this unique endocardial or also endothelial marker. Then we have this fibrosis marker, which is, for example, alpha SMA. So this, obviously there's a lot of fibrosis. I mean, this is corresponding to this area here. We have the nuclei. So we can identify that these are actual cells. And then we merge all of these three pictures, histological pictures. And what we see is that these green endocardial cells no longer are green, but they become this yellowish tint, the majority of them. So what this means, they are overlapping. So they have both markers now. So they are not only endocardial cells, or endocardial endothelial cells, what they should be. So this is what they should look like. But they have a second marker because they transition now to fibroblasts. And this is why they become yellow. So that's the gold standard to determine whether or not this process of changing of these endocardial cells into mesenchymal cells, or in this case, fibroblasts, is actually taking place. And we can also say that we looked at the markers. So these are, for example, the markers that identify endothelial cells. And we have control tissue and we have EFE tissue. And you can see there is a lot less endocardial markers present. There is a lot more alpha SMA and FSB1. These are markers for fibroblasts in these EFE tissues. And these are the transcription factors that regulate this process. So if these transcription factors are upregulated, then these endothelial cells lose their function as endothelial cells and become these extracellular matrix producing mesenchymal cells. Or I'm just, for convenience, I'm just going to be referring to them as fibroblasts because I'm not going to go into more detail with regard to what kind of cells these are. So fibroblasts, which are part of the mesenchymal cell population. So is this true? Well, simply because whatever we do, we question ourselves and try to establish our findings through different methodologies. That's another methodology to look at it. Another methodology where it just really look individually at every single cell that is in this EFE tissue and compare it with age-matched healthy tissue. And you look at it on a single cell level and look at the RNA on a single cell level. And just without understanding anything what I'm talking about, when you just look at the single cell population in EFE tissue and in control tissue, they are different. And what I'm going to tell you here is that this is actually this population of fibroblasts that I just referred to in the histological pictures. In addition to that, what you can also do is to figure out where do these fibroblasts, specifically this group of fibroblasts, where do they come from? And you can do this also through bioinformatics analysis by just looking into whether or not these also co-express endocardial markers, and they do. So this is just another way to look at this aspect of, so what happens to these endocardial cells and what is the origin of EFE? What is also interesting is the fact you can do cell-cell interaction analysis and you can do cell projection analysis. So what happens on a single cell level is, yet again, controls, so age-matched controls and EFE cells are different. And so what you see here is that under normal circumstances, when we look at single cell interaction, we see that cardiomyocytes drive whatever is going on the cellular level, which is no longer true in EFE tissue because all of a sudden fibroblasts take over. So fibroblasts are now the drivers, are in the driver's seat with regard to the remodeling of the function. Also, it's not only the remodeling, but also the function on a cellular basis. So what drives? So now I've shown you that we have sufficient evidence that there is some kind of simulation of endocardial cells that is pathological, that makes them undergo this phenotypical cellular transition, becoming fibroblasts, which then create all of this extracellular matrix. So, but we also have to determine what happens, why does this occur? Especially from a therapeutic point of view, we need to understand what are these endocardial cells exposed to make them transition in this pathological process. And we yet again stumbled upon our own data by just basically going back and looking at our own EFE patients. And we stumbled upon this specific patient. This is not only a single patient. So we reported this on a patient cohort, but this is just the one that I picked because it is very impressive. So this is a young patient that underwent multiple EFE resections. As I said, EFE comes back, and that's our major issue. So this is the initial presentation, and this is just this black is just augmentation. This is just image augmentation. So this is not really stained in black. These are just regular H&E stains, but just for presentation purposes, I made it appear black to give you a better idea. So it's rather superficially the first time at a very young age the patient presented, and as you can see, it infiltrates into the underlying myocardium, and this is one of the last the last presentations. The patient hasn't come back yet, so she is now 3.5 years out, which is very good news for us. However, in this process, in these stages, I show you one of the aspects why we believe, or why we hypothesize that there is more of this EFE growing, and it's growing more infiltratively. It has to do with this horrible picture of flow alterations. Because what you see here is at some point, so this is a patient with Schoen's complex. So at some point, the mitral valve couldn't be repaired any longer, and the patient received a Melody valve. And you can see from the profile of the Melody valve, it's kind of weirdly positioned. It's just a matter of the valve itself. It's a valve profile, and you can also see the jet toward the septum and the apex of the heart. And I hope you trust me on that, but this is the area where EFE developed. And this is just one of our poster childs, but we have recaptured that in several of our patient populations. And this is all published information. So we have published these papers. So basically, the next step for us was to determine whether this is actually true, and whether this is true on the cellular level. There is not much known about the endocardium. We are right now in the process of determining the magnitude of these flow alterations, the magnitude of these wall shear forces. So basically the shear the blood imposes on the endocardium under pathological and physiological conditions. So we recently published a methodology using 3D echo to measure that, and now we're in the process of validating that in a case control series of EFE patients and of healthy H-match controls. So that will be coming out soon, hopefully sooner than later. But sometimes this is only wishful thinking because the research takes time. So as I said, we don't know much about the endocardium, but we do know a lot about the vasculature. I understand that the endocardial endothelial cells is not necessarily one-to-one translatable to the endothelial cells in the vasculature, but at least it's a good start. And what we know about the vasculature is that the vasculature has certain areas that are prone to flow alterations. Basically, the areas where you get atherosclerosis. So you get atherosclerosis at bifurcations. So the flow profile changes to a turbulent flow profile, and that is where you get the endothelial cell changes. So how is this all regulated in the vasculature? It's regulated that by producing this transcription factor KLF2. It's called cripple-like growth factor 2. This transcription factor is responsible, if upregulated, that happens during laminar flow, during physiologic conditions. The endothelium stays quiescent and doesn't have any response. But then induction of turbulent flow reduces expression levels of KLF2 significantly, and these cells undergo this same process that I've just shown you on a cellular level by changing into mesenchymal cells, into fibroblasts. And this is what atherosclerosis is all about. So what happens to prevent atherosclerosis? People are treated with statins. Statins, however, have this very unique side effect or pleiotropic effect by not only on the cholesterol metabolism, but they also interact by upregulating this transcription factor. If this transcription factor is high, you have healthy endocardium, healthy endothelial layers in the vasculature. If it's low, which is during turbulent flow or during the atherosclerotic process, you get plaques. You get exactly like the same kind of remodeling process on a cellular level as you see in EFE. So we took this information to our advantage and figured whether or not we can utilize statins. In our case, we use the lipophilic statin, atorvastatin, simply due to the fact there is a considerable amount of information available on this statin. And secondly, it is due to the fact that it's a lipophilic, so it enters the cell easily. And first, we went into cell culture by just looking at healthy in this case. Now we're looking at really the endocardium again, because we don't know whether or not this is true for the endocardium as well as what I just showed you for the endothelium. So we used endocardial cells, healthy ones, and we used endothelial cells, endocardial cells from our EFE patients. And we isolated them, put them in culture, and exposed them to pathologic conditions. No flow is pathologic because laminar flow is healthy. But pathologic is either no flow or high shear forces, so turbulent flow. And in this case, for the purpose of this presentation, I only shown you the no flow. So pathological flow plus atorvastatin. And what we found is, this is just again the marker in order to determine whether or not these cells stay endocardial cells or not. And when you look here, this is an untreated. So over time, they take on more a fibroblast type of morphology. But then if you treat them with atorvastatin, they remain endocardial cells. So cell culture has a lot of flaws, has a lot of inaccuracy, especially the fact that you put a single cell type on a plate, and that doesn't necessarily mean that this is also true in vivo. So you need to do this in a whole heart preparation. So you need to understand that in a physiologic system, where the heart is in its normal environment, exposed to all different types of biological stimuli, this is also true. And we developed a model like that. Not going to go into detail how it works, but as you can see here, this is this blue coverage of the left ventricular cavity. And you can also see that there's a lot of blue infiltrating everywhere into the underlying myocardium. So this is typical EFE that I showed you in humans. This is for this animal model. And when also, if you believe me, these are also pictures where we show there's a lot of this morphological change from endocardial cell to fibroblast going on. And if we give atorvastatin, this is repaired. So we prevent EFE formation in this animal model. This is a preclinical model where we have now, this is just one of the treatments that we're pursuing, but this is one that we could convincingly show, even in a preclinical model, that it reduces EFE formation. The second interesting aspect about it is that the reason why picking atorvastatin also, I could go and pick any kind of inhibitor that uniquely and specifically binds to some kind of receptor that I've identified. The problem is that will take another 10 to 15 years in order to be able to introduce it for clinical use. This is a different story. If we use FDA-approved drugs, because that is a lot lower hurdle in order to be introduced in the clinical setting. And statins are already used off-label in children to treat primarily familial hypercholesterolemia, but they're also used off-label for the diseases like Kawasaki's or others. So this is just on a cellular level again to show you that this is true what I'm telling you, that this is really regulated all through KLF2. So basically, this shows what we did here is on the cellular, we just blocked KLF2. So what happens if we block KLF2? What can we do? Can we still, is atorvastatin still beneficial? No, it is not. So what we show here is that if you permanently block KLF2, you cannot restore this healthy phenotype of endocardial cells. So it's another step in the right direction to get to confirm that this is true. This work has recently been accepted for publication in JACC, as Journal of the American College of Cardiology, basic translational science. So what I would like to conclude for today is that I believe I have convincingly shown you the fact that endocardial fibroelastosis is one of the pivotal problems in restricting the growth potential of the left ventricle. And in addition to that, it negatively impacts outcome in the sense of preserving the left ventricle for use in a biventricular circulation. The underlying mechanism of EFE formation is this phenotypical switch of endocardial cells to mesenchymal cells, to basically fibroblasts, which then are responsible for production of this subendocardial and infiltrative invagination into the underlying myocardium of collagen and elastin, blood flow alterations, so turbulent flow as a consequence of valvar diseases, which are an integral part of this congenital malformation, trigger EFE formation through the process through in KLF2, so this transcription factor, which is responsible for maintaining a healthy endocardium. And if we target KLF2 through atorvastatin, we can inhibit this process and prevent EFE formation. And that has been shown in preclinical model. Everything else is a matter of the future, and we will see. And we are in the process of planning clinical trials in order to confirm that this is true. Thank you very much.
That is amazing. Thank you very much, Ingeborg. Thank you very much.
No, thank you very much for having me.
No, this is very good. You show a lot of advances, and I remember a lot of things that I told with you and Shogo when he was there. And I don't know if someone in the audience if you want to make a question, go ahead. I have so many questions, but I begin if you want. The first question that I have is the model that you use in the preclinical study is the Shogo model that I remember.
Yes. Yes,
Okay.
it is this model. Yes. So it's basically I have to point out this is not the animal model is not a hypoplastic left heart syndrome model, because this is very, very difficult to do, because Ignacio can tell from personal experience animal models are very, very difficult to design, because what you have to do is take a healthy heart and impose a congenital disease on it, and that rarely works. So we developed an EFE model, so a rat model, or also mouse model, that where we can induce this transformation of endocardial cells into fibroblasts and create this subendocardial thickening. So this is the preclinical model.
Okay, and the other question, I have two more questions. One is, I remember when you use the cell culture, when you apply a shear stress force, how the endothelial cells change to mesenchymal cells. I remember, and this I remember when showed me this, and this is how you understand better in the cell culture the mechanism. No, this is the way,
right.
Or okay.
Yes. So the cell culture model basically just takes endocardial cells, healthy and diseased. So diseased is, I mean, I get the tissue directly from the operating room, and then we isolate the cells that are in this tissue, and we get age-matched control. These are really healthy hearts, and then we expose them either to nothing, just let them sit in the petri dish and let them grow. That's no flow. This is a pathological condition. Or we expose them to laminar flow. Laminar flow is basically what these cells see under physiologic conditions. And through our investigations, we did serial experiments where we determined, so what for our cell culture model, what is physiologic and what is pathologic. And we understand that around 10 dynes per square centimeter, this is physiologic exposure of shear forces on these endocardial cells, and then everything above is pathologic. So we just picked 40 dynes simply because, I mean, this is for sure pathologic, and this also corresponds with, I very, very briefly mentioned that we have a study going on right now that determines shear forces in vivo by 3D echocardiography, and that's kind of where all of this information comes from. So pathologic no flow in 40 dynes, and these cells transform into fibroblasts.
The last question that I have is, do you know if in the clinical area any doctor use any statin to prevent the fibroblastosis? Do you know if
we will? So we're in the process. We are right now in the process of discussing what kind of clinically FDA approved, clinically available by off-label use medications we can use for our patients. I only picked atorvastatin. We have a lot more medications that we've been testing. That's just one. because I mean, it would definitely blow this 35 minutes of lecture to introduce all what we have been testing successfully. But yes, we will be using atorvastatin as treatment.
Okay, I don't know, Martin, are you there? Or Martin is the chief of resident in our service now. He's a fellow for cardiovascular surgery, and I don't know if Pablo Garcia, he's the head of the service, is there. Anyone have any question?
Hola Nacho, sí, estamos acá.
Do you have any question, or it's okay?
I think it's a little bit overwhelming to get this much information in this very, very brief period of time.
Yes. And what I remember, and you showed something about the growth factor, the transforming growth factor beta, and I remember that you have the idea to use intra-layer molecules to inhibit this factor. Did you make any experiment
Yes.
with this, and what happened?
Yeah. So this growth factor, TGF-beta, is the main growth factor that promotes fibrosis, not only EFE, but just in general. So whenever we talk about tissue fibrosis anywhere in the body, you can guarantee TGF-beta is involved. So TGF-beta has interesting role because it is also involved in the pathology of Marfan syndrome. So in Marfan's, due to the genetic mutation, TGF-beta is upregulated. So in Marfan's patients, TGF-beta inhibitors have been used to support these patients. And as I said, I'm more convinced to stay with medications that are FDA approved rather than search for some kind of small molecule. We did try to look into the inhibition of TGF-beta directly. We did this through two mechanisms. One was to look at losartan. Losartan is an antihypertensive medication that has also this unique effect. It's an angiotensin 2 receptor inhibitor, and that downregulates TGF-beta. We've published this work, and yes, it inhibits EFE. The other way to look at it is to look at TGF-beta more on a regular level. So TGF-beta is an interesting growth factor. It is a whole family of growth factors. So TGF-beta comes in isoforms 1, 2, 3, 4, but it also has in part of the same family has its own antagonist also. So for example, during valve development in utero, during early stages of heart development, the valve development is driven by TGF-beta, but it needs to be turned off because otherwise our heart will be full of valves, which we don't want. So it needs to be turned off. And it's this balance within this TGF-beta family that turns it off. So sometimes TGF-beta is upregulated and sometimes its inherent antagonist is upregulated. And the inherent antagonist is called BMP. That's bone morphogenic protein. It doesn't make any sense. The terminology doesn't make any sense. We use that to our advantage by just using this BMP growth factor and upregulating and just basically giving it in our preclinical model. And yes, it does inhibit EFE. The problem with BMP is it used to be FDA approved for use in orthopedics, but it was taken off the market. So it's no longer available. So therefore, that cannot be used as an indirect TGF-beta inhibitor. But losartan, absolutely, that's also something that we're discussing with regards to clinical trials.
You know a lot. I have another question, big question is, when the patient had fibroblastosis, is a restrictive myocardiopathy in the ventricle, and this is the mechanics that this is the reason that why the cavity of the left ventricle can't grow, or are other factors that when you have fibroblastosis, the muscle cells, the myocytes, adapt to this inhibition or something like this? Do you know something about that?
Yes, I do. Because you're asking all the questions that we're asking too. So, interestingly, when you look at the hypoplastic left ventricle, it is not that the wall thickness is too thick. So it's not a hypertrophied ventricle, but it's the volume, the cavity is too small. So if you take this restrictive tissue out of the cavity, then you normalize this relationship between left ventricular volume and left ventricular wall thickness. Having said that, is the cardiomyos, or is the myocardium of a hypoplast normal? Data point to the fact, no, it is not. And also what is not normal is the interaction between the EFE endocardial cell and the myocard and the underlying myocardium. So there is, we have a pretty good idea what this cell-cell interaction is pathologic for endocardial cells in underlying myocardium, and that is at least this is what we hypothesize, and we have some preliminary data to support that, is also responsible for this infiltrative growth pattern. Oh, absolutely. Yes, yes, we have an idea, and yes, it's not only the endocardial cell, but it's the cell-cell crosstalk that is also affected by this pathology.
Thank you very much.
And in addition to that, I also have to point out, as I said, I make it simple and just call it fibroblasts. It's not that simple. It's also it's the transition from an endocardial cell to a fibroblast is a multi-step process that is to a certain degree reversible, and so it will give me another 10 years of research to focus on, let's put it this way, and which I look forward to.
Obviously, thank you a lot for to give your knowledge to us. It is very important for us, and thank you again. I don't know if someone else with a question. I don't know. If not, I want to say thanks for our team, and I send a letter to you for our head of the service to say thanks, to give to us your knowledge.
Thank you so much. It was a real pleasure. Thank you so much. Thank you for the invitation.
Muchas gracias, Ingeborg. Muchas
gracias. Hasta luego.
Hasta la próxima.
Saludos, abuelo.